Mic check. Mic check.
Yep, I can hear you.
Of Medicine Grand Rounds. It's my great pleasure today to introduce our Grand Round speaker, Dr. Marcus Tony Urey. Dr. Urey is an assistant clinical professor of medicine in advanced heart failure and cardiac transplantation and serves as the medical director of the heart transplant program at UC San Diego Health. Dr. Urey received his MD degree from UCLA and did his residency in internal medicine at UT Southwestern, followed by a fellowship in cardiovascular disease and an advanced heart failure and cardiac transplantation fellowship also at UT Southwestern. During his training, he was the recipient of the John S. Miller Award for the Outstanding Senior Resident and the Outstanding Teaching by a Fellow Award at UT Southwestern. He has also received a Faculty Teaching Award during his tenure here at UCSD. Dr. Urey specializes in advanced heart failure, mechanical circulatory devices, and heart transplantation. He has a particular interest and expertise in managing end-stage congenital heart disease and cardiac amyloidosis. He works closely with colleagues from different subspecialties to offer these patients the most up-to-date treatments, including access to clinical trials. He serves as the primary investigator for the Cardio-TT Transform, a study to evaluate the efficacy and safety of eplontersen, formerly known as Ionis TTR LRx. He also serves as primary investigator on a study of mavacamten in participants with HFpEF and chronic elevation of C-troponin I and NT-proBNP. Dr. Urey served as the National Hispanic Medical Association Council of Residents state representative for the state of Texas. This is a national organization dedicated to empowering Hispanic physicians to be leaders through political change and pursuit of academic careers. We're fortunate to have him here today to speak to us on amyloidosis care at UC San Diego Health, a model for a complex multidisciplinary team approach. Thank you, Dr. Urey.
Thank you for the very kind introduction, Dr. Simmerjot. I'm very excited to be here. Thank you for this opportunity. I'm going to be covering and discussing amyloidosis, a little bit of a different approach. We'll go over some of the science behind it, but I want to focus on the approach at UC San Diego for this very potentially devastating disease. These are my disclosures. So I was asked to give an example of what interested me in amyloidosis. I'm going to take you back to Texas in 2013 when I was a first-year fellow in cardiology. And one of my attendings admitted a patient, a 40-year-old man, history of recurrent syncope. He was previously diagnosed with pulmonary hypertension or HFpEF. It was a little bit unclear. When he was admitted, we got the standard testing, including an electrocardiogram that showed frequent premature ventricular contractions. He otherwise was a normal sinus rhythm. And he was admitted specifically for evaluation for sarcoidosis. Him being African-American, a young man, and having abnormal EKG was what prompted the attending to consider sarcoidosis as his condition. An electrophysiology study was performed soon thereafter after his admission, and was negative for any inducible ventricular tachycardia. So really, we didn't have a good explanation for his syncope. He was discharged with a life vest, and an outpatient PET scan was recommended. When I saw him during that hospitalization, I reviewed his echo, and being a first-year fellow, didn't know too much about it, but was concerned that maybe there was something else we were missing, an infiltrative cardiomyopathy. And that's when I inquired and pushed a little bit, what about the diagnosis of amyloidosis? Is that a possibility? And I was told he's a little bit young. Sarcoid in African-American population is more common. So we neglected that diagnosis for the time being. But prior to discharge, we sent off, convinced the group to send off the standard testing. Unfortunately, he was discharged and had an episode of syncope at home. His 3 teenage sons tried to resuscitate him. He was in PA arrest when the ambulance got there, and he expired soon thereafter. His autopsy showed extensive amyloid deposition of course, we got the results from his testing that also confirmed amyloid. So of course, that was pretty traumatic for the family, also for me as a first-year fellow, but also prompted me to try to pursue this diagnosis, this disease, raise awareness, and then hopefully not have the same outcome that my patient had almost 10 years ago. Before we talk about AL, his diagnosis was light chain amyloidosis. I think it's important to take a step back and just really consider what amyloid means. It's a little bit confusing and sometimes a little bit overwhelming for providers and for patients. And fundamentally speaking, amyloid is a disease of protein misfolding. That's the most basic way to think about the disease. It's characterized by an extracellular deposition of what we call amyloid fibrils. What happens is that the body makes a number of proteins. In amyloid disease, we have protein misfolding, and these misfolded proteins will then aggregate and then form these amyloid fibrils that are dominated by something that I'm sure many remember from the textbook, beta pleated sheets, very rigid structures that don't allow for the body's normal mechanism of proteolysis to take care of that. There's over 30 types of amyloid. And we're not going to go over all of these in detail, but I will highlight a handful of them. Certain fibril types have a tropism for certain organs, and that's not well understood why light chain has a tropism for the heart and the kidney and the liver, or why a different form like AA may have a tropism for the kidney specifically. But we know that they share a very common pathology or pathophysiology. And I have listed here different models, AA, AL, and ATTR, and I'll go into a little bit of detail in the future slides. But I just want to highlight that these all have the same fundamental process of protein misfolding, inability to excrete or take care of those misfolded proteins. Why do we need a multidisciplinary team? And I'm going to go over this towards the end, but just to highlight how big of an issue this can be. There's over 30 types, and I'm not going to be able to go over all the different forms, but I hope you can at least appreciate that multiple organs are at risk when you think of amyloid disease. The nomenclature, as you can see here, A is the first letter in all of the different forms. That stands for amyloid. The second letter describes the precursor protein. So for AL, it's light chain, amyloid of light chain. TTR, amyloid transthyretin, and so on. Again, there's 30 forms, some of them that affect only a specific organ, such as AA, predominantly a kidney disease, and some that can be systemic, such as light chain that can affect really any organ or any tissue in the body. For our discussion, we're really going to focus on two forms, light chain and transthyretin, or AL and ATTR. And a couple of reasons for that. One is I'm a cardiologist, so this is the main type of amyloid that I see. It also is important to recognize that light chain, or AL, is the most deadly form of amyloid disease. So that's why I think that one warrants special focus. TTR has recently surpassed AA amyloid as the most common form of amyloid in the world. And that's largely driven by really just different modalities of diagnosing it. It was somewhat of an academic pursuit for years since we didn't have any therapy. So we didn't necessarily look for TTR that often. So what is AL amyloidosis? So I've already shared the pathophysiology, very similar in all forms of amyloid. But AL amyloidosis is a disease that I consider to be on a spectrum with other plasma cell dyscrasias, such as multiple myeloma, Waldenstrom, smoldering myeloma, and it originates in the bone marrow. It's a plasma cell clonal expansion that will lead to overproduction or an excess production of light chains. And here is a picture that you can probably recall is the immunoglobulin, which is made up of a heavy chain and a light chain. In this condition, the kappa or the lambda subunit of the light chain will be the protein precursor that leads to amyloid. Cardiac involvement is very common, with 50% of patients having some degree of cardiac involvement. And besides the heart, kidney and liver are the other two most commonly involved organs. Now, the estimates of how much we actually see in the United States is probably not accurate. And in 2018, that's the most recent publication, we estimated approximately 3,000 patients in the US that had this condition per year. More recent publications, and I would probably submit to you that most amyloid experts think this is a pretty dramatic underestimation. We're probably in the order of 6,000 to 10,000 patients per year. Most of these patients, and I'll contrast that with the patient I presented to you at the beginning, most of them are over age 60, but we can see it before age 60. And organ involvement really dictates and determines prognosis, with heart involvement having a median survival of less than 12 months and nerve involvement being about 34 months. I just want to again refresh everyone's memory and just highlight again that this is a very common pathophysiology shared amongst all forms of amyloid, where you have a production of a protein in excess. In this case, it's made by the clonal expansion of plasma cell. Excess free light chains are made. These are unstable and will aggregate, and then again form these prefibrillar aggregates that will then form fibrils. The fibrils, the characteristic that leads to disease is that they're resistant to proteolysis, and that's because of the beta pleated sheath. Unlike other forms of amyloid, AL specifically is very toxic. So if we look at tissue sampling, we'll note that there's much more edema, there's more injury to the adjacent cells. Compare that with other ones that it's more of a disruption of the architecture of the tissue. Light chain amyloid is very, very toxic. And these are some of the manifestations shown at the bottom. The two that I want to highlight is periorbital purpura and macroglossia, which is pathognomonic for AL. The other things that are noted there, cardiac involvement, renal involvement with nephrotic arranged proteinuria, are not necessarily specific to AL alone. Now, I'm gonna speak a little bit more on TTR, and AL is managed predominantly by a hematologist or bone marrow transplant specialist in collaboration with other organ subspecialists, depending on what organ's involved. TTR, largely, at least in the United States, is a cardiac disease, so I'll focus a little bit more time on this. And just again, nomenclature A for amyloid. TTR is the precursor protein. In this case, it's transthyretin, or transporter of thyroxine and retinol. And this is a protein that's made in the hepatocyte. Almost 95, maybe close to 97% originates from the liver. The rest of it comes from the choroid plexus and retinal epithelium, probably negligible till we consider the amyloid disease. But as you can see depicted here, the liver makes a homotetramer, 4 identical subunits that will circulate and essentially are transporting thyroxine. To some extent, most thyroxine is free-bound, and also vitamin A or retinol. In the disease, in the amyloid disease, you'll see that there is dissociation to monomers. These monomers, again, misfold, and I keep mentioning misfolding because that is fundamentally the problem with this disease. And these misfolded proteins form aggregates and then fibrils that we know go into tissue and cause the disease state. There's 2 forms, wild type, or as many probably recall from the literature, senile. We thought of it as an age-related amyloid, where the DNA sequence is completely normal, no alterations whatsoever. It's sporadic, not genetic, and not clustering with families. And then the more aggressive form, but also the much more rare form, which is the hereditary form, where there's a single amino acid mutation in the TTR gene. It's an autosomal dominant inheritance pattern, not 100% penetrant. So we know patients may be at risk with a genetic alteration, but not necessarily manifesting the disease. And this does lead to systemic disease, even though, again, we do highlight that cardiac involvement is very common and often the dominant sign or symptom. In terms of why do we see amyloid and how challenging is it to diagnose, and I'm sure those that have seen this probably appreciate that patients may come to you after being told nothing's wrong with them or being misdiagnosed or bouncing around from different providers before the diagnosis is made. And the challenge is best, I think, exhibited by the TTR model of disease initiation and propagation. TTR is made in everyone. It's conserved across all mammals. So we expect TTR production to happen in everyone. Now, the disease happens when we have TTR made in excess of what the body can clear. So that's when TTR production is greater than excretion or clearance. And at that point, you have residual TTR protein that will disassociate and lead to this cascade where you have fibril deposition. And that also you can see depicted here on a time continuum. But the lag phase is really when you have the normal protein and then you start making that in excess. There's some disassociation. You start forming these fibrils. And then once you start forming fibrils and depositing into tissue, propagation happens much more quickly. You don't need actually that much more. So a patient may describe to you, they come They've had 10 years, they were doing fine, very active. And then at some point they can describe a point in their life where everything just fell apart, where they notice they're falling off a cliff almost because symptoms, whether it's cardiac symptoms, neuropathic symptoms, are progressing so rapidly. And often it's hard for patients and even for providers to understand that this process has been going on for maybe 10 years or more. There's this thought that there may be a threshold effect. We don't really understand that fully, but that is something that is at least described as a hypothesis. This is another way of considering it. Imagine a patient that has a genetic mutation and is at risk for TTR amyloidosis, the hereditary form. We know that the initial process is when they're born. They're born with a genetic mutation that puts them at risk for the development of transthyretin amyloidosis. Many years can go on before the patient has no apparent disease. And even if we had assays or ways to assess amyloid fibril burden, it probably is not contributing to any significant organ dysfunction. Then you get to the point where there's so much amyloid circulating, it becomes sticky and it's attaching to organs, and you have this undiagnosed disease or subclinical phase that can go on for years. If we were to go and biopsy organs like nerves, we would see axonal destruction in those that have hereditary TTR. If we biopsy the heart, we may see also deposition of amyloid, but they don't have any evidence of organ dysfunction, no small fiber neuropathy symptoms, no heart failure symptoms. So the disease may be delayed, or the diagnosis may be delayed. And then you may get to the point where you finally have signs and symptoms, or maybe you had a family member that was diagnosed that led to an earlier diagnosis. But at that point, there's an abundance of amyloid in the tissue and the propagation is much quicker. So we want to diagnose early because we know that we don't recoup or regain with the available therapies what we lose. And I think this image really shows the delay in symptoms based on how much amyloid has been deposited. Now, when we think about phenotypes across the world, the United States is interesting because we see senile or wild type amyloid. That's the dominant form of TTR amyloidosis. And it's typically, we think, a disease of white males above age 70. That's the most common presentation. The average age is about 70 years of age for the wild type form in the United States. It's mainly cardiac. Not really associated with other organ dysfunction, except maybe some musculoskeletal involvement that is still being explored. For the hereditary form in the United States, the most common patient population at risk is African Americans, and I'll discuss that why in the future slides. When you contrast that with the rest of the world, you see a very different phenotype. In Western Europe, particularly Portugal, Sweden, and also in Asia, mainly in Japan, those populations have been well genotyped. And we see that the polyneuropathy, which I'll show later on, is the main presentation. And this is a very aggressive polyneuropathy that's life-limiting. Typically, the average age is around 40 or so, and equal distribution between male and female. The mutation that I'm going to highlight is valine 30-methionine, and I'm going to discuss that later on in some of the next slides. I don't expect anyone, even when I get a patient with a mutation, I often have to go to the literature and review what the manifestation typically is. And that's because there's over 130 of them. Some of them that only sequester in certain parts of the country with one family that's been genotyped and phenotyped. So we have right now about 130 different mutations that we're aware of. Columbia had a registry called the Thaus registry, and we looked at the most common mutations in the United States. And I've already alluded to this valine 122 isoleucine that accounts for almost a quarter of patients. It's the most common mutation. African Americans are the ones at risk. And this is a gene that originates from West Africa. And during slave trade, it's sequestered in the Americas, in the Caribbean, and in parts of South America, particularly Brazil. Threonine 6-dealanine, more of mutation seen in those of English and Irish descent. And then valine 30-methionine, I've mentioned that one already, is more of a neuropathy. Now, if you look at textbooks or if you discuss with people that are in this field, we often try to attribute a dominant phenotype to these mutations. So either neuropathy or cardiomyopathy. And you can see from this image here that most will fall on a spectrum of having varying degrees of both. But typically we try to identify which one is dominant because that has some prognostic implications. Also, in terms of some anticipatory guidance on what their clinical course may look like. But it really is a fallacy to consider it to be a heart or a neurologic disease alone, because when we look very closely at patients that are well phenotyped, we see that most patients have an overlap of multiple organ. And this is really why we think of the hereditary form of TTR as being a multi-system, multi-organ disease. I'm just gonna really quick comment on the two extremes. So the V30 methionine has almost 90% a sensory neuropathy. And as you can see here, there's still a significant cardiomyopathy, about 30%. So it's not really a neurologic disease alone. It really is a mixed phenotype, but it has varying degrees of organ involvement. And then valine 122 isoleucine, as you can see here, it's almost 100% cardiac with less polyneuropathy, but it's up to 60%. So these patients may come to you and have heart failure presentation. But if you delve down into their history, they've had a sensory neuropathy for a number of years. We may attribute it to a number of things that may be more common, like diabetes, and we have other reasons for that, but it's something worth considering. I won't go too much into detail, but gastrointestinal symptoms, and that can be malabsorption. It could also be dysmotility, is very common also, and often is attributed to things like IBS. So, patients often will say, well, I've had this for the last 10 years and no one was able to figure out why. I was put on Bentil or something for symptom management. It may be amyloid. The cardiac manifestations are variable. And I have patients that are the same form wild type or hereditary, and some that present with sudden cardiac death. That can be an initial presentation, and some that present with just progressive exertional intolerance. They were running marathons 5 years ago, and now it's taking them twice as long. Arrhythmias are very common, atrial fibrillation being the most common. Ventricular arrhythmias are a little bit less common, probably a little bit underdiagnosed, but not as frequent. And also conduction disease. So a patient that has recurrent syncope, one of the things I always consider is intermittent heart block, which is a very poor prognostic indicator. Most patients, though, will have this history of shortness of breath over a number of years, 5, 6, 7 years, before you actually see the dramatic signs of volume overload. We all talk about amyloidosis being a classic restrictive cardiomyopathy, which is true. But the signs of right-sided failure, volume overload, swelling, that's fairly late presentation. They often will have biomarker elevation, troponin, NT-proBNP, without evidence of volume overload. So there's this uncoupling of pressure and volume in the heart. And then later on, you start seeing the true, I would say, the more classic presentation of heart failure, where we have congestion and also fluid retention. And then cardioembolic disease also can be seen. I don't think, in interest of time, I'm not going to go over the details of arrhythmia management or device management, but I do want to highlight one of the former residents here, who's a cardiology fellow at UC Davis. We wrote a paper that reviews the electrophysiology or the management of arrhythmias and devices in patients with cardiac amyloidosis. The neurologic manifestations, and I'm not a neurologist, so I hope I don't say anything wrong, but I do see this quite often. The neurologic manifestations are typically broken into sensory deficits or sensory neuropathy, which is an earlier sign, a motor neuropathy, which is later, and then dysautonomia or autonomic neuropathy, which can be variable. And we have implications in terms of prognosis. This is specifically for the hereditary form. This is how we look at and grade TTR. FAP or familial amyloid polyneuropathy stage 1 is a disease limited to the lower limbs. And just like other axonal polyneuropathies, it's link dependent. So the lower limbs are first affected. And FAP1 describes a patient that has sensory deficit without need for assistance with ambulation. FAP2 is when you already need a cane or a walker, and then 3 is the end stage, bedridden or wheelchair bound. And these also have prognostic implications. There's other scoring systems that our colleagues in neurology will often use, but this is the way I think about the polyneuropathy. Now, this is a more dramatic case of a patient over time. This is basically the natural history, absent any therapy, for the hereditary form of polyneuropathy. This gentleman is from Japan, has a valine 30 methionine mutation, was diagnosed in his late 30s, had sensory deficit. And then over time, you can see that there's more neuropathy as, just more neuropathy develops over time. At the end stages, it's a pretty dramatic neuropathy that also leads to protein wasting, significant GI disturbances, malabsorption, and the patients die from electrolyte derangement, from heart failure. Their end stage does not look like the classic heart failure presentation, but it is one that essentially is terminal. This is, unfortunately, this is in the time period where there was no therapies available. We've made some advances since that time. Although I'm going to really focus on the cardiac and the neurologic manifestation, I want to remind everyone that what we said earlier on, it requires multidisciplinary approach because it is a multi-organ disease. And if a patient comes undifferentiated to you and has amyloid, and we suspect it's cardiac amyloid, my assessment typically, unless I already have a suspicion of what it is going to be fairly comprehensive, a full assessment of all the extra cardiac manifestations. If you already know, sometimes they come and they had a fat pad biopsy, they had a colonoscopy and someone identified amyloid. If you already have the diagnosis, then you can somewhat tailor your assessment to see what organs may be at risk. I've mentioned earlier on that purpura and macroglossia are pathognomonic for AL. Carpal tunnel syndrome can be seen. Cardiac, renal, and hepatic involvement, very common. And that's actually, I didn't have listed there, gastrointestinal and neuropathy. So those are some of the assessments, at least questions that I would ask. Wild type, we typically think again as a cardiac specific disease, plus the musculoskeletal aspect. And that's being really researched more in detail now. We thought of bicep tendon rupture and carpal tunnel as being the associated musculoskeletal presentation, but we know that now rotator cuff injuries, hip issues, osteoarthritis, lumbar stenosis, there's other manifestations. And these are all kind of like compressive neuropathies, so compression by infiltration of the ligaments. And then hereditary, again, is also a systemic disease. I typically think about doing a full assessment of all this, the different organs that may be at risk. Now, when we have a suspicion for amyloid, whether it's a history or the family members were at risk, or really anything, maybe it's a biomarker. They were in the ER and the troponin is really elevated for maybe shortness of breath. They had a angiogram, it was negative. Some of the echocardiogram findings can be very classic, and some of these listed here for the non-cardiologists in the audience are very classic for amyloid, but also very classic for late presentation. So I don't necessarily suggest that we wait for some of these to develop before we start the evaluation. Once you see this, a very significant thickening of the posterior and the septal wall of the heart, very enlarged atria, also some diastology parameters that suggest a very stiff and heart that can't relax. Those are, again, very classic signs, but that patient is probably an extremis, has pretty significant heart failure and functional limitation. When we do echo, many places, our center does this often, we'll do strain, cherry on top sign, which basically looks at strain at different portions of the heart, of the left ventricle. And if we see that the apex, which is depicted by the bullseye plot, if the apex is preserved and we have decreased strain elsewhere, that pattern is consistent with amyloid, not pathognomonic or not diagnostic. It's consistent. And I say not pathognomonic because Dan and Fabry, other genetic cardiomyopathies that some of my colleagues have researched have also shown this pattern. But at least you may exclude HCM, hypertrophic cardiomyopathy, hypertensive heart disease, and athlete's heart. So it may be helpful when you're a little bit unclear on what the diagnosis may be. So if we have an echo, whatever your screening tool, maybe MRI, if you suspect amyloid, the first step that we always suggest sending is an evaluation for light chain. And I didn't give light chain much time, but I again want to highlight that this is a much more deadly disease, warrants immediate attention and collaboration with the hematology bone marrow transplant group. So we always want to screen for that. And the screening test, I typically will send serum, electrophoresis, urine electrophoresis, and that can be a spot urine, and also kappa lambda serum-free light chain. If you can serum and SPEP and UPEP is helpful, the UPEP does require a 24-hour collection. Then I also send troponin and NT-proBNP. They're both prognostic in all forms of cardiac amyloidosis, but also informative. If you see a very elevated troponin or BNP, you're more likely to have AL. And that's because, again, the toxicity associated with AL. So you see really, really elevated, like in the tens of thousands with the BNP. If your workup is negative, if your workup is positive, that's when I get on the phone, I call Caitlin Costello and some of my other colleagues on the BMT side, ask them, can you get them in within a few days and get their workup completed, which includes often fat pad bone marrow biopsies and additional lab studies. And then if it's negative, and then you proceed down the path of non-invasively assessing for TTR. We use pyrophosphate. And I'm not going to go over all the nuances of making the diagnosis, but I do want to highlight that we now have a non-invasive way of diagnosing TTR, which again is the most common form of amyloid that causes organ dysfunction in the world. So we don't have to go to heart biopsy. That's not done and not always done well at all places. We can use this type of study. It's a nuclear scan, which will light up if you have fibril fragments. So these are what you would get in an imaging study, and this would give you the diagnosis of TTR amyloid with fairly good sensitivity and specificity. There are some caveats that I won't really discuss on patients that if you have a very high suspicion and it's negative, there's some reasons why that may happen, and it still may warrant further testing, further imaging. The algorithm that I use, and it's pretty universal, everyone really follows this algorithm, is if you have a suspicion, whether it's echo, MRI, or other imaging modality for amyloid, the first step, it's always going to be assessed for AL. Once you've excluded AL with the requisite testing that I've mentioned, at that point, we say no plasma cell dyscrasia. We go down the non-invasive path to make the diagnosis, and that's the imaging study pyrophosphate scan. If you have a positive pyrophosphate scan and you have the diagnosis of TTR, at that point, we send genetic testing, or at least recommend genetic counseling and consideration for genetic testing. There's implications, of course, for family screening and cascade testing, and also now implications for therapies that may be available only to those that may have the hereditary or mutant form. The prognosis is really dependent on the type. So I've already highlighted that AL is the deadliest form of amyloidosis, particularly if it affects the heart. And the prognosis really is, when you do staging or try to assess what the prognosis is, it really is important to assess which organs are involved. So if you have heart, kidney, liver, every organ has its own staging system. I'm going to just show the heart staging system. That's the one that I use most commonly. And it really is from a paper in 2012 out of Mayo Clinic that looked at patients at time of diagnosis, pre-treatment, how they would fare after initiating therapy. We're in a different era. This was 10 years ago. This was also when some of the therapies we use now for AL were not available, or people were going to bone marrow transplant because we didn't have that good option. So it's a little bit of a different era, but I think it would still highlight that a late presentation still has a fairly bad prognosis. As you can see here, we use these three criteria: troponin levels, and that's the assay that was used in the publication, but we have a different assay now, so there's some changes to that number. NT-proBNP, and the difference between the kappa and lambda. So those three, if you meet those cutoffs, you get 1 point, and that will essentially give you your score, stage 1 through 4. Stage 1 being meeting zero of those criteria, stage 4 having all three. And importantly, that's what we see will drive mortality if there's heart involvement. Stage 4 has a prognosis of 5.8 months, so a very dismal prognosis. And this is in patients that received treatment. They were treatment naive at time of developing this staging system, but very poor prognosis. For TTR, we use a number of different assays. There is a staging system that I won't really discuss because it may not be that clinically applicable. I think it's a little bit hard to use it, when a patient sits in your office and they ask you what their prognosis. What's more important is to look at their genotype. If they're wild type, that typically has a better prognosis. And also look at their other, kind of factors. If they have a poor functional class, that has a poor prognosis. More advanced New York Heart Association, of course, has a poor prognosis. And then biomarkers, we use BNP troponin. The publications have shown anywhere from about 2 to 5 years average survival at time of diagnosis. But again, I want to just highlight that this is in a different era. We're doing better at making the diagnosis. So hopefully the prognosis is different now that we catch the disease earlier and intervene sooner than we used to. AL amyloidosis therapies, this would, really warrant a full hour discussion, and it should be given by a bone marrow transplant or a hematologist. But I want to highlight daratumumab. This is a landmark trial, Andromeda, that was published last year in 2021 in the New England Journal of Medicine, and it really changed the way we think about this deadly disease. Daratumumab is a CD38 monoclonal antibody, and we know that that protein is overexpressed in myeloma cells. Some other cells may have it, but really myeloma-like cells have it, and it targets that. On a background of bortezomib, cyclophosphamide, and dexamethasone, we saw that in this trial of almost 400 patients that were enrolled in a one-to-one fashion, that we had essentially freedom from major organ deterioration or hematologic progression. This is what led, this Andromeda trial was what led to the FDA approving the first therapy specifically for AL amyloidosis. Everything else that has been used up to that point, including the standard of care, cyclophosphamide, bortezomib, and dexamethasone, was based on myeloma data or myeloma studies. So this is really an important trial that I mention often and I highlight often because it really has changed the way we think about this disease. Importantly, some of the patients that are most vulnerable, the ones that had really advanced CKD that were progressing to end-stage renal disease, or those with very advanced heart disease, were excluded. So it's important to recognize the limitations. That being said, my colleagues in bone marrow transplant are very aggressive about using this therapy, even in the more advanced patients, because we know that it's well tolerated typically. For TTR, we also have a pretty exciting recent years. The last 5 years, we've seen therapies become available in a disease that was pretty much a death sentence for most patients. The therapy of choice before this became available was NSAIDs that were used off-label. And in the neuropathy world in Europe, it would be liver transplant because, again, the origin of the protein is in the liver. So you would try to transplant them early enough before you saw the more advanced signs of polyneuropathy. Just to remind everyone, this is the pathophysiology of the disease, where we have TTR production. It's a stable homotetramer that will then become unstable. These these monomers will then misfold, form fibrils. So we really try to attack this process in multiple different, areas of the pathophysiology. Suppression at the level of the liver, trying to block TTR from even being produced. We know that's probably safe in the short term. We don't know the implications of suppressing TTR for decades yet. And we have available therapies, patisiran, vutrisiran, and inotersen. TTR stabilization. So imagine now the TTR that's stable, locking it in this homotetramer stable configuration. That's tafamidis, and then off-label use of diflunisal. And then investigational trials are looking at removal. So can we use monoclonal antibodies, bind the protein or the amyloid that's been deposited, recruit macrophage, and eliminate fibrils that way? That's still in trial. And just another way of looking at it, the United States, we have these 3 therapies up top for neuropathy, the ones listed in black. For cardiomyopathy, all we have is tafamidis. That's the only agent we have. We likely will have a second agent, patisiran, somewhere in the end of 2023. That's already been submitted to the FDA for approval, and UC San Diego will be an early access program site for that therapy. So some of our patients may be able to qualify for that. Now, I wanted to just end the last, I guess, 7-8 minutes and just talk about the vision we had in terms of creating an amyloidosis center here at UC San Diego. What was the rationale? And I hope that I've outlined a little bit about how devastating this disease, the importance of collaboration with a number of colleagues. But initially, when we first decided and started talking about having an amyloidosis program, we decided who would be the core players. And again, really highlighting that TTR and AL are both the most deadly and the more common. Our core team was established, including bone marrow transplant, cardiology, and neurology. After that, we recognized that there would have to be provider awareness. This is a disease that is often missed, and there's other ways that we may be able to find it, whether it's engaging the echocardiographers that are looking at it. Maybe the first person that may notice that this looks abnormal may look like an amyloid heart. So we did that through engaging the community with different disease state talks and also different conferences. At that point, we had a lot of interest and excitement, but at the same time, we needed really support from multiple subspecialists that could really target symptom control, symptom management. And that's when we reached out to a number of different divisions for support. And it was not shocking to us, but it was pretty exciting to see how quickly everyone was excited to join our efforts and really take this on. Then we wanted to focus on standardized patient evaluation. That means that if a patient comes in for transthyretin amyloidosis and was being seen by Dr. Carolyn Mulroney in the BMT group, she would reach out to one of the cardiologists, and we would ensure that the patient would be seen in an expeditious fashion, get the full testing and therapies if available. And that was fairly consistent with everyone in the group, a commitment to try to get patients evaluated quickly. Naturally, we started discussing these patients in a monthly multidisciplinary group meeting, which included patient review and also journal club. And as soon as that happened, we also were in an era where the FDA was approving a couple therapies in the span of a few years. And this is again in a disease that previously had no treatment options. So our PNT, our pharmacy committees, and also our clinic really was aggressive about having this available at UC San Diego immediately after FDA approval. I've already mentioned clinical trials, and there was also a really big emphasis on community outreach, understanding that a multidisciplinary team makes sense only if we can actually reach the patients that are most at risk and vulnerable. This is a pre-pandemic, of course. We were actually able to huddle and meet in person. This actually doesn't look that different from what it was. It was a small room in ACTRI. We sat down, we met, and we were discussing, short-term goals and long-term goals. And eventually we developed this algorithm, and I don't have the full details of it on here. It's a little bit busy. But this is our kind of our pathway for the most common form. So AL, TTR, if we get a referral, we'll try to triage it, or it may just land in someone's clinic. And then at that point, there's extensive communication that happens fairly quickly. We try to identify what form of amyloid they have, who's the appropriate kind of champion for that patient, whether it's a BMT physician, a cardiologist, a neurologist, and then they'll bring in the other subspecialists as needed. Most of the patients that have complex or multi-organ involvement are discussed at our meeting. And then again, we have other subspecialists there. This is the majority of patients that are on the amyloidosis team. The providers. There are a number of others that recently have joined that I don't have listed there or shown there. But as you can see here, we have a representation from different divisions across the campus. And we have other groups that are interested in joining, including ophthalmology. I didn't mention much of that, but that may be one of the early signs. So we're very excited to see that there's excitement from other departments. The community outreach really is, I think, a testament of having a university in a city that really has a lot of at-risk and vulnerable populations in the surrounding communities. So as you can see here, this is our main focus, San Diego. We have El Centro, Palm Springs, the Temecula Riverside area, and also South Orange County. I do want to highlight Las Vegas. It's a very large African-American population. There's no amyloid center. There's really no one doing that routinely. So a number of us got Nevada licenses, so we were able to provide collaboration and consultation. The pandemic actually, I think, showed us that telemedicine was a viable way of providing care. So Las Vegas is actually one of our biggest referring centers for patients, particularly the V122I mutation in African Americans. So where are we today? Well, I think we have to take a look at where we were in the past before we can acknowledge where we are today and the advances we've made. We used to think about amyloid disease, in particular TTR, of how we can look at the disease. Oh yes, this patient came to me and they had TTR these last 10 years. There's more retrospective analysis, more of an academic discussion. We define the disease as categories, phenotypes of neuropathy, cardiomyopathy, and didn't really delve into the details much. We'd focus on management of symptoms. If they got short of breath, we give more diuretics. And then the treatment goal was slowing disease progression with certain therapies, not necessarily the underlying etiology of the disease. Patients continue to live with disability and very short lifespans. Now we've moved, I would say, pretty dramatically in that regard. Now we see patients and we want to see them in a timely fashion, see them as early at the earliest point where the disease may manifest. We want to have multidisciplinary care, ask our colleagues in different divisions to evaluate what may be the earliest sign of organ dysfunction, make the diagnosis, and then focus on holistic care. A reason I say holistic care, because sometimes we don't necessarily have pharmacotherapy, but there are proven non-pharmacotherapeutic options that may be available. Also, many patients may be candidates for things like organ transplantation or bone marrow transplant, which of course takes a lot of buy-in from the patient and also is a higher risk procedure. The treatment goal has changed. We don't necessarily just want to slow disease progression. We want to halt it. Exactly wherever we find it, we want to halt it. That still highlights the need for us to diagnose it early because we're not really, again, we're not going back in time and stopping organ deposition. We want to find it early. And our goal is to lower the burden of disability, but also improve life expectancy. So how does this translate to our patients? This is from a UCSD press release. And I want to highlight really the pharmacy at UC San Diego that was motivated to get a therapy that's very expensive that became available, and also the clinic staff. Our UCSD was the first to have a therapy available just a few months ago. And this is our patient, Nancy, and her dad. Both of them have a hereditary form of TTR amyloidosis. It's manifesting mainly as a neuropathy in Nancy. She didn't know about it until her dad was diagnosed, and then she had genetic testing. He's more advanced and had a heart transplant, but they're both doing very well. And she was the first person in the world to get the commercially available Amvuttra. And again, I want to just highlight the pharmacy dedication and also the clinic staff in making that happen. But I think when we think about our multidisciplinary approach, this last case is the one that really highlights how far we've come from when we first started. This is a 40-year-old man. I think a few folks in the audience may know this patient, who presents to the emergency department with 2 months of lower extremity edema. He also has dyspnea on exertion and also foamy urine. His workup at his local hospital, which was Balboa, the Navy hospital, revealed nephrotic range proteinuria, 9 grams, and a biopsy revealed AL amyloidosis. This was confirmed by Mayo Clinic. He was started on the standard of care, Cyberd and daratumumab. So unfortunately, in spite of him beginning therapy, his kidney dysfunction worsened. He eventually went on dialysis. And then he was admitted to our center after he was referred to the BMT group because of decompensated, what looked like cirrhosis and heart failure. That's what it looked like to us, at least. This was in spite of getting regular dialysis sessions. We started doing paracentesis, and in the hospital, he required it every 2 weeks. Twice a week, removing 5 to 8 liters every session. And we weren't sure, is this a cardiac or a liver etiology? And then we saw on the biopsy that his hepatocytes or the sinusoids were completely obliterated by amyloid. We also saw a gradient of 12, which is extremely elevated. That's consistent with portal hypertension. And in spite of him getting the appropriate therapy, BMT was very aggressive with getting him everything he needed. Also considering that he had multi-organ dysfunction, was very sick and very frail. His heart also worsened and his biomarkers were rapidly increasing, suggesting a very poor prognosis. About 5 months or so, And this again is only taking into account his heart, not really acknowledging that he also had other organs involved. He was referred for heart, liver, kidney transplant, which it is a big deal, even though I'm talking about it a little bit nonchalantly. But when we approved him, this was the first time we had ever embarked on a 3-organ transplant. He was approved on December 16th. It was quite interesting committee meeting, over 50 people attended. And in the hospital, he waited, deteriorating. We actually weren't sure if he was going to make it to transplant because he was getting multiple complications from just having end-stage liver, heart, and kidney disease. His heart, liver was done on February 14th. The kidney was done a few hours later. That's pretty standard. We do the kidney to follow. And this is the first ever in the literature reported multi-organ, or I should say 3-organ for AL amyloidosis. I just want to highlight the OR course. I'm not going to go into too much detail, but it does highlight the complexity. And this is a timeline, a paper that one of the surgeons and I published. It's accepted recently, but it really looks at the time of in the donor OR, the time of procurement of organs, when the heart started, when we first cross-clamped the aorta, the liver transplantation, when that was completed, the mandatory stabilization in the ICU, and then the kidney transplant. And this is looking at 8-month data. This is 8 months after transplant. His ejection fraction and his cardiac parameters are normal, as are his liver, and his kidney, his creatinine suggests a GFR of above 60. This is Tony, one of our patients, who is 40 years old. He's 22 years in the Navy. He was at Balboa, then transferred to us. He's almost, I guess, 10 months out, doing very well. And obviously, this is a huge deal to be able to have some time with his family. We expect him to have a long life that he otherwise would not realize. And he has a wife, a lovely wife, and a 6 and a 3-year-old son. So with that, I would just want to end with the future goals is collaboration. I've mentioned, and I alluded to carpal tunnel. So collaborating with hand surgeons, maybe they're the ones that should be telling us when they find amyloid and asking us to do the full evaluation if there's other organ involvement. Also with some of the basic scientists are interested in our tissue samples, doing proteomics. We know that different forms of amyloid lead to different expression, and some may help really understand why we see some patients have such bad organ dysfunction with certain types. So that's something that we're in discussion. We're currently doing a project with our colleagues in Italy and Portland, Oregon, using SGLT2 inhibitors. I think SGLT2 inhibitors probably work for anything. So that's what our rationale. And then we plan to have an inaugural amyloid symposium sometime next year. The pandemic kind of pushed things out. I wanted to do it in person. So we're hoping 2023. We have current grant submissions for clinical startups, which would include nurse coordinators. And with that, I'll open for questions, and thank you for your attention and time.
Dr. Urey, thank you for that thought-provoking presentation. We have a question from the audience from Dr. Shahado. How many AL cardiac patients are being followed by UCSD, and how many are newly diagnosed each year?
That's a great question. I probably wouldn't be able to give you the full answer right now. Not all the patients are brought to the entire committee. Some of them have just one organ involvement, and they may have very mild disease. So it's not always presented to the entire committee. I would say that easily we're upwards of 20 to 30 patients that are diagnosed every year, new patients with AL amyloid. That's probably an underestimation. I'm only really accounting for the ones that I'm aware of, which all make it to cardiology. I think my bone marrow colleagues would probably be able to give a better answer, but I think it's a reasonable number of patients.
Yes, Quinn.
So the question is, what about daratumumab monotherapy? I hope there's not too many people from BMT on, because I may say something wrong. Daratumumab monotherapy, though, has been studied and has been looked at. And the biggest benefit you get with daratumumab is that you get rapid drop in serum free light chain, which is thought to be the main reason for organ toxicity. So if you can eliminate the serum-free light chain level, you can see organ improvement sooner than if you kind of delay time to get what we call a hematologic complete response or a very good partial response. So there is myeloma data showing daratumumab as monotherapy. I do have patients I co-manage with Caitlin Costello, Aaron Goodman, Carolyn Mulroney, and some of those patients have been on monotherapy alone because it is well tolerated. It's a sub-Q injection. Some of the other therapies like bortezomib may have neuropathy as a side effect. Cyclophosphamide has drug-induced liver injury. There's other reasons for intolerance. For a lot of our heart failure patients may not be able to tolerate a lot of dexamethasone. So in short, I don't think there's a trial in AL amyloid with monotherapy alone. There is myeloma data, and that's applied to AL amyloid patients. Yeah, so that probably is best answered when you think about a predictable patient population. What are the efforts really in those that are at risk for the hereditary TTR? There are some data that shows that initiatives to try to identify at-risk populations, namely those with HFpEF that are readmitted to the hospital, or African-American population above 50 with heart failure, with preserved ejection fraction. Those are the ones we should target. There's mention of that. Is there actual initiatives that are promoting, full-on screening? Not that I'm aware of. And there's collaboration with different advocacy groups, really identifying at-risk populations, which are often disenfranchised populations or those that have socioeconomic determinants of health that also suggest the worst outcome. So a little bit of a challenging answer, but for the hereditary population, there is. Thank you. Yeah. So it's CRISPR-Cas9. It's not for the fixing the mutation. It would be applicable for wild type and hereditary. It was done in the London group, and they basically created a knockdown. So they didn't fix the mutation because there's multiple mutations. You'd have to do 130 plus different forms of gene editing. They basically turned those patients that had hereditary form into knockouts. So it's in the conserved region of TTR. And I think they did like 9 or 10 patients, and they showed success in basically eliminating TTR, which should eliminate amyloid disease, with the caveat that we don't know if TTR suppression for decades is going to cause other effects. That trial should begin in the United States. Intellia is the pharmaceutical company that's running that trial, and we are in discussions to be a site for that. Hopefully we have that available. And that would be open to hereditary and wild type, so to both patient populations. But it is, I think, one of the new exciting kind of therapies that's in the pipeline. I think a lot of people are excited about it. I have strong opinions, but that more has to do with accessibility, because gene editing is not going to be accessible to the highest risk populations, which in the United States still is, ethnic minorities that don't always have access. So.
Outstanding. Thank you again, Dr. Urey. I want to let all of you know that we will not have Department of Medicine grand rounds next Wednesday due to the Thanksgiving holiday. We hope to see you again in 2 weeks. Thank you. Thank you. Well done.
Thank you.
I guess I'm theoretically your boss. Nice to meet you.